So students, the INI-CET 2020 is over. I hope you all did in a great way. Yes, few of them have told that it was quite a tough question. The pattern is keep on changing. There is no room for older questions, repeat questions, factual questions. Yes, these INI-CET is always been a difficult exam to crack upon. It may look like simple questions, but the question has deeper meanings. Similarly, in ENT, there were 5 questions that have been asked. So apart from 2 questions, other questions were quite new or bit tricky. Okay. So now we are going to discuss the ENT questions that have been asked in INI-CET 2022. First, we'll start with this question. This was the easiest question in ENT. It was a previously asked question that was asked in AIMS 2020. So identify the correct sequence of auditory pathway. The pathway has been given in the form of A, B, C, D, E. So we have to make the correct sequence of this auditory pathway with the options that have been given. So first we start with how the auditory pathway will be there. First one is, we should always remember this mnemonic E, E, O, Li, Ma. Yes, this holds good. So these 2 for 8th cranial nerve. Here, C for cochlear nucleus. Olivary complex. L for lateral lemniscus. I for inferior colliculus. M for medial geniculate body. A for auditory cortex. Clear? This is how E. coli will stand out. This is how sound that reaches the inner ear will get traveled to the cortex of the brain. Now the sequence here, the first one is cochlear nucleus, then superior olivary nucleus, then lateral lemniscus, then inferior colliculi, then medial geniculate ganglion. So it could be B, A, D, C, E. So the question which was asked in this NSET cannot be the exact question, but I'm revising you the previously asked question in AIMS 2020. This is the actual content that have been asked in the INI-CET 2022 exam. Okay. So now we can proceed to the next question. This was quite a newer question. This was not asked previously in any of the exams. This, if they have started asking this question, it's quite headache for all those preparing with image based questions. So you should be absolutely clear about the diagnosis in otology. So there are too many things that have been seen in otology. You should be clear with all those findings in otology. So this is one such question. At 40 years, patient coming with a history of foul smelling discharge, hard of hearing. Which of the following will be the grade of otoscopic picture? First thing is, what they are coming to tell? They're coming to tell about attic involvement, or we can call it as squamous type of COM or atticoantral type of CO7. So with the help of the question and the close, they have given it as, so it is an unsafe type of CO7, atticoantral or squamous type, whatever. So for this unsafe type, they have given the picture like this. See, So they given picture like this. The picture holds that there is some retraction that is seen over the pars flaccida. Pars flaccida. Retraction that is seen over the pars flaccida. So in pars flaccida, this retraction is seen. So what is the grade of this retraction? So if we haven't studied this grading, we can't answer this question. So first, we'll jump into grading of this pars flaccida retraction. So the pars flaccida retraction is being classified into 4 types by TOS. TOS classification. Okay. So grade number 1 is there is a mild dimpling in the pars flaccida. Mild dimpling in the pars flaccida. You could see small contact with the neck of malleus. So it's a very small contact. You can't appreciate this very easily, but there is a small dimple and a contact that is not so evident. Clear? This grade 1 TOS pars flaccida retraction. See here. So the retraction is obvious and the contact with the neck of the malleus is very, very prominent, which is grade 2. Which is grade 2. So contact with neck of malleus. Clear? Yes. This is grade 2. Grade 3 is, see here, the bone that is above the pars flaccida, we call it as scutum. The bone that is above the pars flaccida, we call it as scutum. So in the scutum, if there is a partial erosion, so grade 3 is retraction of pars flaccida with partial erosion of the outer attic wall. The outer attic wall is otherwise called as scutum. Here, so outer attic wall or scutum partially eroded. So grade 4 is complete erosion of the outer attic wall or scutum. Complete erosion of the outer attic wall or scutum. Clear? So this holds good for TOS classification of pars flaccida retraction. It is an unsafe type of CSM or articuloantral type or squamous type. Now we should also know the retraction of the pars tensor. They ask us series classification. So series classification gives grades for pars tensor retraction. So here pars flaccida is normal. Here pars tensor is retracted. See, this is a minimal retracted pars tensor where you could see a lusterless TM. So it is very dull, no? Lusterless TM. So no cone of light. You could see no cone of light. Yes. So if it is very much minimally retracted, you could see the handle of malleus. But so here you could start seeing some contact with the incus. So beyond the malleus, we could see the long process of incus, but in this picture it is not clearly seen. So it is only small contact or near contact with the long process of incus that you could not appreciate very clearly. But as per the description of the grading, so retraction of the pars tensor with near contact with long process of incus. Okay, this is grade 1 of SADE pars tensor retraction. Grade 2, see here. So it is very retracted such that you could clearly see the contact of the tympanic membrane with long process of incus. This is grade 2. So contact with long process of incus and sometimes with stapes suprastructure. That also you could not see clearly here. So it is not very clear in this picture. So, but the contact with long process of incus is very clear. Okay. Now look. So the tympanic membrane is starting to plaster over the medial wall of the middle ear. So what is the middle of the middle ear? It contains promontory. See here. This is actually the tympanic membrane that has started to plaster over the promontory. Clear? Yes. Here, some areas are still in the actual position, but almost 75% has been plastered to the promontory. Retraction and near contact with promontory is grade 3. We also call it as atelectasis of middle ear. We also call it as atelectasis of middle ear. Now, see here, complete plastering. See, complete plastering of the tympanic membrane with the medial wall of middle ear. So you could confuse yourself with this. This is nothing but granulation. This is nothing but granulation. You don't worry this. Mostly grade 3, grade 4 contains enormous amount of granulation. So you should also be able to differentiate whether it is a granulation or it is a polycythoma or it is plain retraction packet. So here there is plain retraction packet where there is complete plastering of the tympanic membrane with medial wall of the middle ear. So plastered upon the medial wall of the middle ear is called as adhesive otitis media. It's called as adhesive otitis media. Now there is another grade called grade 5 where there will be atelectasis like this and also a perforation like this. So a retraction with perforation is grade 5. So you may ask, so if there is a perforation, it could be grade 5. See, if there is a perforation, usually there will not be retraction because already the tympanic membrane is not intact. Then how could it go inwards? No. Only if the tympanic membrane is intact, there will be a formation of retraction packet. Now here, grade 5, there is retraction. After retraction, there will be formation of spontaneous perforation. So it is grade 5. Okay. So that completes our discussion about TOS classification of pars plana flexor retraction and SADE classification of pars tensor retraction. Now we get back to our question that has been asked in INI-CET exam. So here, what is the grade? So there is no erosion of the scutum, only contact with the neck of the malleus. So it is grade 2. Grade 2 TOS classification of pars plana retraction. So that completes our second question for the discussion. So now let's enter into our third question for the day. A patient complains that he feels like the room is spinning when he gets up from lying down or turning his head. He has no history of loss of consciousness and he is diagnosed to have BPPV. So the question itself, the answer is given as BPPV. So in BPPV, they quotes that there is an horizontal nystagmus. Yes. If the slow component is towards the left, which of the following could be true? So if the question doesn't has the term BPPV as diagnosis, the discussion would have been different. But the BPPV has been given. So I hope it is not a bigger concept that is revealing or hiding inside. It is an easier concept. So first, let me explain what are the traps that they have given. So if you would have learned about the complication of the CSOM, the important complication is labyrinthitis. Complication is labyrinthitis. In labyrinthitis, if you are having right side, left side, yeah. So right side semicircular canal is there, left side semicircular canal is there. So if the entire labyrinth has been filled with some inflammatory particles, so it is hyperactive labyrinth. Yes. So it is seen in serous labyrinthitis. So if this is the case, if there is serous labyrinthitis, there is hyperactive labyrinth, it irritates the semicircular canal and the direction of nystagmus will be to the ipsilateral side, that is same side. Clear? So the hyperactive labyrinth, it is serous labyrinthitis, it has been irritated, it causes ipsilateral movement of eyeballs, that is direction of nystagmus is ipsilateral. Now irritative ipsilateral, you can remember like this. Now if there is a purulent labyrinthitis, there is a pus formation inside the labyrinth, purulent labyrinthitis, there will be destruction of the labyrinth at some parts. So it causes hypoactive labyrinth. It causes hypoactive labyrinth. If it is hypoactive labyrinth, there will be nystagmus to the contralateral side. So hypoactive purulent labyrinthitis, which is causing nystagmus direction to the opposite side. So based on the, so why I am telling you this, options were right hypoactive labyrinth, left hypoactive labyrinth. So if the hypoactiveness is being given, it means that there is some problem within the labyrinth. It could be a purulent labyrinthitis. It has caused the labyrinth to be hypoactive. If the hypoactive labyrinth was the case, the nystagmus may move to the left side. Yeah. But in BPPV, it will not be like this. If there is a right side BPPV, it is depending upon the direction, depending on the fast component. Clear? If the slow component is to the left in this BPPV, the fast component will be to the right. So it could be a right-sided BPPV. Whether the options are given as right-sided BPPV, left-sided BPPV? No. The options are given as superior semicircular involved or posterior semicircular canal involved. Does superior semicircular canal involvement, posterior semicircular involvement, lateral semicircular involvement has distinctive features? Generally, no. If you are having a BPPV, whichever semicircular canal is involved, you just have to look upon the direction of the fast component. The direction of the fast component will be the direction of the nystagmus. Right side is involved. Where the fast component is there, that will be the direction of the nystagmus. Now, then how could we answer this question? See, if the BPPV is the answer for this question, it has already been given in this question. So now we can go for what could be the important feature of BPPV. It is posterior semicircular canal involvement. 98% of BPPV is due to posterior semicircular canal involvement, whereas rest 2% can be due to superior or lateral. Clear? So this is how this question can be sorted out. So according to the sources given to me, they told that BPPV is given as answer in this question itself. So the answer could be posterior semicircular involvement. If the option BPPV is not given in the question, then it could be suggestive of labyrinthitis. Then the answer can vary. Now, as we know, this could be the answer for this particular question. Clear, people? Yes. So it rings the alarm bell that anything can be asked in depth when you read about approach to verdict. Clear? So all the questions are going to be asked in depth. No superficial questions are going to be asked hereafter. So you should have a thorough understanding and thorough knowledge of the entire topic, any subject. Okay. Next question. So again, if you are able to read some of the MRI or something about the involvement of the soft tissues in MRI, you could have cracked this question. A 50-year-old man with a history of chewing tobacco has complaints of sticky sensation in the throat. On examination, mass seen extending over the vocal cords. Palpation showed 1.5 into 2 cm primary lesion on left side as described above, and 4 cm level 3 node on the left side. So basically, the nodal staging is given in the form of this description. So it is unilateral, multiple nodes, right? So 4 cm. So 1.5 into 2 cm primary lesion on left side as described above, and 4 cm level 3 nodes. So it is given as some 2 nodes are being involved in this patient examination. So the nodal staging is not very important because all the answers is being given as N2. So we can leave it off N2, nodal staging. Now we can get back to the T stage. So T staging, how we are going to learn about the T stage. Yes. So this is actually a question of CL larynx, probably glottis. Sometimes supraglottis can be asked, some subglottis can be asked. Okay, so what is glottis? It is nothing but vocal cord, anterior commissure and posterior commissure. Clear? Yes. So what is supraglottis? Supraglottis, you should understand the parts. Supraglottis proper, then false cord or vestibular fold, then array epiglottic fold, AE fold, then laryngeal surface of epiglottis. Clear? Yes. So why you should know this? Because so the subdivisions of the supraglottis is very important. Then only you could easily answer the T staging of supraglottis. In glottis, you should just know vocal cord is the glottis. Subglottis 1 centimeter below vocal cords. The area below the vocal cords is subglottis. Now, if we enter into the staging, T1 is very easy. T1. So in vocal cords, T1A, T1B will be there. Other two will not be there. T1A, 1 vocal cords. T1B, 2 vocal cords. Now, I have told you 4 subsites in supraglottis. Yes. So if one subset is involved, it is T1. It could be any subset. It could be a laryngeal surface of epiglottis. It could be a vestibular fold. Any single subsite will be T1 in CS supraglottis. In T2, 2 subsets. So if your tumor involves supraglottis proper and false cord, it is T2. Okay. In vocal cord, either involvement of supraglottis or subglottis. Here that is spread to the adjacent areas. Spread to the adjacent areas. Whereas subglottis, involvement of only subglottis is T1. Spread to the glottis is T2. T3. For every subsites of the larynx, T3 is nothing but vocal cord fixity, which means that if it is a tumor from supraglottis or subglottis or from the glottis, if there is vocal cord immobility, vocal cord fixity, it is T3. So if a question has been given to you, the first thing that you have to analyze is whether vocal cord fixity is given or not. The second important thing that you have to look upon is T4A. What is T4A? Involvement of inner cortex of thyroid cartilage. Inner cortex of thyroid cartilage. So if this invasion is there, it is T4A. This T4A. So involvement of thyroid cartilage is there, it is T4. Here. So if there is distant involvement of carotids or skull base, it is T4B. Clear? So these two things are very important, whether you should look for vocal cord fixity and involvement of thyroid cartilage. Let's get back to the picture. In this picture, this is a earglottis. This earglottis has breached this thyroid cartilage. Has breached this thyroid cartilage. Let us extend. If there is breaching of the thyroid cartilage, it is T4A. So what is the option that has been given? T4N2M. So this would be the answer for this. I'll also make you clear about the nodal staging. So first you have to clear about the subsides of the cervical nodes. One is submental, submandibular, upper deep jugular, middle deep jugular, lower deep jugular, posterior triangle nodes, that is 5, pre-laryngeal, it is 6, mediastinal is 7. Okay, so first we should be clear with the various subsets of the nodes. Now, for almost all of the head and neck malignancy, this nodal staging holds good, and one is less than 3 centimeter. In this question, it is not less than 3 centimeter, it is 4 centimeter. So that's also comes under N2 only. N2A only 3 to 6 centimeter single node. Clear? In N2B, what will be there? Multiple nodes. Multiple nodes, any size. So there is 2 nodes are there. It is automatically N2B. You don't have to look upon the size of the node. N2C is bilateral nodes. Bilateral nodes, any size is N2C. N3A, it is more than 6 centimeter. N3B, extranodal involvement, any size. There is extranodal involvement, that is, there is a skin ulcer over the nodal metastasis. It is N3B. The prognosis is very poor. So this is the nodal staging that you have to learn about while dealing about the staging of CNRs. And any of the head and neck malignancy, most of the staging will be like this. Okay, there are few exceptions like CNS pharynx, thyroid, but most of the head and neck malignancy will be having this nodal staging. The last question was, it was quite a tricky question. High risk HPV does not cause. So if this is the question, high risk HPV, so what are the high risk HPV strains? It is HPV 16 and 18 are the first choice. Okay, second choice, it could be 31 and 33. So you would have learned this in CS cervix. So CS cervix 16, 18 and 31, 33 are all involved. In anal carcinoma also high risk HPV will be involved. Whereas other strains of HPV like HPV 3, 6, 11 are there. So what are the diseases that will be caused by HPV 3, 6 and 11? Whether it will cause anal carcinoma? No. Cervical carcinoma? No. Even oropharyngeal carcinoma will be caused by high risk HPV, not this 3, 6, 11 and all. So again it will be caused by HPV high risk. Whereas laryngeal papillomatosis, which is supposed to be a benign mass. Okay. So HPV 3, 6, 11 can cause laryngeal invasion. Can be classified into 2. Only 3 and 6 can cause JORP. Juvenile onset recurrent respiratory papillomatosis. Clear? Yes. So it occurs in around the adolescent age group, 8 to 14 years of age. So what it will cause? It will cause lesions over the vocal cords. Small papillomatous lesions over the vocal cords. The child will be suffering from initially voice change. Sometimes the child can also have breathing difficulty. So what you could do? You could do microlaryngeal excision of the lesions. So it is not much recurrence noted in juvenile onset recurrent respiratory papillomatosis. Whereas if it is occurs in adults, it is 6 and 11 strain. In adults, 6 and 11 strain. What it will cause? Again, it will cause bigger mass, not smaller mass. Bigger masses like this. See, there will be multiple things. Here there will be only 2 or 3. 2 or 3 papillomas. Okay. What is the treatment for this? Again, it is microlaryngeal excision. In some cases, we can also give injection bevacizumab that will reduce the recurrence. So what it will do, it has more recurrence. So every time you remove this tumor, it will keep on coming again, and it has more chance for turning into malignant. More chance for malignancy. So this is quite a tricky question. You should know about HPV because HPV is on the rise in head and neck tumors. Previously, oropharyngeal tumors was caused by smoking alone. Now it has been caused by HPV due to rise in oral sexual practices. So HPV is an important virus that has been involved in malignancy. You should be having a thorough understanding of HPV, the mechanism how HPV is causing, E6, E7, which are the tumor factors it is affecting. So everything you should be very clear about HPV, and also which are the malignancies, which are the benign tumors that is caused by human papillomavirus. So that completes our discussion about the questions that have been asked under ENT in INI-CET exam. So if you have any doubt, kindly leave in the comment box.